get us rolling. So hello, everyone. Thank you very much for joining us today. I'm Paul Fahey. I'm with New York State OD2A, and I'll be your host and moderator for our conversation. So welcome. We're glad you're here, and this is an important conversation. I'm going to turn it over to Josh and Kaylee in a moment for our presentation, but I wanted to just go over a couple thoughts and ground rules. First, if you're watching this on demand in the future, this is being recorded on March 18th, 2021. And I mention that because some of the things that we're talking about, policies and procedures and things, may change over time. So I wanted to keep that in mind. We have this as a meeting format instead of a webinar. When we first started this series, we had a webinar format, but felt much more like a monologue. And really the purpose of this presentation, this meeting, is a dialogue. It's sharing information, but we want to make an opportunity for folks to, certainly tell us what's on their mind, share experiences and ask questions. So to that end, a few thoughts. Would love to have you put thoughts and questions in the chat as you're going along, even just words of affirmation, love that idea, me too, et cetera. But if you have questions for our panelists, I'll be moderating and I'll disappear in a moment and give them the stage. But I'll try to keep an eye on the questions. I think they can both see them as well. So we'll try to answer in real time. But if there is something in particular that's very narrow or might pertain to a particular circumstance, we'll try to take those answers offline after the webinar. We're going to launch a poll in a minute just to get a sense of what folks' familiarity is with New York Matters and also your job type, and just so we have a sense of the perspective. And I believe that that'll help us to tailor this conversation much more as we're kind of going through. So it'll help us make this even more relevant. So if you have a moment, for those of you not joining by phone that are here live on Zoom, first, would love to learn a little bit more about you, maybe put where you're at in the chat. I know we have some folks even on Hawaiian time, some very early birds in our Hawaiian and Aleutian time zone, and folks across the country. So good morning, good afternoon. Thank you for joining us. So we'd love to hear where you're from. And I'm going to also, I think, Kaylee, launch the poll now. Good time to do that, just so we have a sense of folks' experience. Okay.
Yep, that sounds good.
Okay. So I'm going to launch this poll and I'll leave it up for a couple minutes and give folks a chance. We really just want to know if you've heard of New York Matters and what your job category is. So thank you. I see thoughts and notes coming in. Kaylee and Josh, are you also able to see the poll results? Okay, great. Then I won't report out on those. I'll admit some more folks in from the waiting room. So let me briefly introduce our panelists. I'll start with Kaylee Loughran. She serves as a program coordinator for New York Matters. She recently completed her bachelor's degree in psychology at the University of Buffalo. And while pursuing her degree, Kaylee gained experience in the medical field working as a patient care technician in an emergency department, a nursing assistant, and as a research assistant on a clinical research program. She plans to continue her education and attend medical school. So thank you. Also joining us is Dr. Joshua Lynch. Dr. Lynch is an emergency physician and EMS medical director from Buffalo, New York. He is a senior physician with UB-MD Emergency Medicine and holds faculty appointments at the University of Buffalo and Lake Erie College of Osteopathic Medicine. Sorry, thank you. Dr. Lynch has spent over a decade in EMS leadership and several years as the system medical director at Mercy Flight of Western New York, Aeromedical and Critical Care Transport. Dr. Lynch is also the creator of New York Matters, which you'll hear a bit about today. This program works to provide efficient buprenorphine training to emergency physicians and create linkages between the hospital and substance use treatment programs. He serves as a technical advisor for the Erie County and New York State Departments of Health. And he and his team are very proud to have received more than $1 million in grant funding to support the Matters program and widely expand access to high quality addictions care. So the team is also greatly appreciative not only to their partners at the New York State Department of Health, but also contributions to the electronic referral platform. And we are thrilled to have them both here today. So with that, I will disappear as moderator and I'll let you folks, I think Josh, you'll start sharing slides and get us rolling here.
Great, thank you very much, Paul. All right, we good with the slides? Excellent.
Yes.
So thank you for having us again. I appreciate the introductions. We will keep an eye on the chat box. So if you have questions, please submit them in. And what our goal is here is to run through really kind of what the New York Matters program is. But I want you to think about, how referrals work for patients that are either in the emergency department, in the hospital, at an urgent care, at a primary care office, being released from jail, how they look from the scene of an EMS call or an interaction with police where someone may not be actually incarcerated but interacts with the police and then is released. So think about that, and that's real. All of those examples are really why we wanted to create a platform and a process that would be very easy and efficient and both user friendly for either the doctor or the PA or whoever is referring the patient, but most importantly, easy for the patient. And you'll see kind of how we used to do things and really why we wanted to change things and the way that patients were not only assessed initially, but were referred, and mostly what options they would have when they were sitting in front of the doctor, either in the emergency department is where this all started, but then obviously all kind of from a different variety of settings as we've continued to expand. So before we really start talking about that, I want you to just kind of take a step back for a second and think about and kind of imagine either yourself in opioid withdrawal, or if you know somebody that's gone through opiate use disorder and you've interacted with them or heard about how opioid withdrawal feels like, it feels horrible. So think about that and think about going to the ER, either in withdrawal, hoping for some help, or after an overdose, going to the ER and expecting some not only courtesy, but also linkage to a place where you can go get better. And for a very long time, none of that happened. And what really happened was patients would come to the ER and we gave them a list of clinics that they could call. And we all felt great about that interaction. And the list was given to the patients, and the patient may call a number. And it turns out that when we really looked at the list, most of those numbers didn't work. So we really were doing quite a disservice to patients by handing them a list of phone numbers that made us sleep at night and let them go home to really provide no other benefit and really accomplish nothing by their ER visit. And to be honest, we knew we could do better as we continued to hand out the list of phone numbers, but it was never really at the front of our minds. And solving opioid use disorder patients' linkage to care and all the barriers that come with that, whether it's no insurance, no transportation, no job, polysubstance use, really to most people always kind of felt like an intangible and unfixable problem. So we started to think about what would we want, or what would you want as a patient coming in, trying to get care, wanting to be linked to a place that could simply take care of you. We have no problems doing this for patients that come in with chest pain that need to see a cardiologist. We'll bend over backwards to get them a stress test, or hooked up with a GI doctor to get an outpatient scope or something like that. So I think that the answer about what patients and doctors would want would be something that would put the patient first, to let them pick where they want to go. A group of primary care, a group of outpatient treatment organizations that would take the patient no matter what. So they would offer the same amount of choices to the patient that has insurance and a job and a car as the patient that doesn't have insurance, has no transportation, is a polysubstance user who has been through multiple attempts at rehab. And that's really where the Matters program comes in. And there are a whole bunch of obstacles that I think some of us are familiar with some of them. Some may be familiar with all of them, but there certainly are no shortage of barriers and obstacles for patients to navigate through to get to a point that they're getting high quality care, either as an outpatient or an inpatient. And some of those barriers are direct things that the patient needs to get through that are challenging for the patient, but also some of those are challenging for the doctor. So we understand that medication assisted treatment or MOUD, medication for opioid use disorder, is evidence-based to work, to keep people in treatment, to retain people going to their appointments, and for them not to continue to use opioids. Now, there's additional training that has to go on in the form of buprenorphine waiver training or an X waiver training. We have elements of our program that include easy access buprenorphine waiver training. Additionally, I think, as the pandemic has accelerated the evolution of telemedicine, we have elements of our program that can provide care to patients either in their home or on the street or at the police station via telemedicine. We work with correctional departments, whether it's at the state or the county level, to treat inmates that are about to be released, just the same as we would treat a patient leaving the ER. So putting in front of them a whole range of options where they want to go and get treated when they're being released from prison or jail, which we understand is one of the highest risk points of a patient's life where they may fatally overdose, is shortly after leaving a period of incarceration. Harm reduction, several of our partners are harm reduction oriented. We understand that not everybody's ready to go from 0 to 60 and overnight. And what I mean by that is going from an overdose to meeting with a counselor and a psychiatrist and whoever else at a clinic and really kind of jumping all in. Some people need a couple steps along the way, and harm reduction really is a great way to do that. Home induction, we realize that not everybody's ready for a medication like buprenorphine when they present, whether maybe they're not in withdrawal, maybe they just used a few hours ago. So home induction is a big part of our program. Inpatient consults, we affectionately call that SUIT, Substance Use Intervention Team. That is built to assist hospitalists and other specialists on the inpatient side if they're not sure how to manage a patient that may be managed on buprenorphine or methadone as an outpatient. They come in and they need an appendectomy and have additional needs for pain control. So we can help the hospitalist or help the primary care inpatient team work through that. You'll learn all about the electronic referral platform, and you'll also learn all about medication vouchers. So if you have a minute or you're a multitasker, jump over to newyorkmatters.org. It's all spelled out. There's just like a 4.5-minute explainer video really walking through the program. So if your colleague of yours is interested to hear what you've been doing this afternoon, jump over to the video and you'll learn all about the program in just a couple minutes. So if we have to boil it down even simpler than that, looking at prescribing, access to medication in the emergency department or in the hospital, and providing rapid and efficient referrals is really what this program kind of works itself out to be. So I'll just show you, to give it a little bit of a geographical perspective for those of you who aren't from New York State. Our program started in Buffalo. It quickly grew to the rest of Western New York. We are working on some future partners that you see kind of along the New York State Thruway between Rochester, Syracuse. And we've built kind of another regional network in and around the greater Albany, Saratoga, Schenectady area, and have kind of working our way down the mid-Hudson Valley into New York City and onto Long Island. So these are our current partners today that are referring patients, all on the same electronic referral platform, no matter where you are in the state. So back to the prescriptions, MAT, access, and the ED, and efficient and effective referrals. This is really kind of the first step, which was optimizing controlled substance prescribing. And many providers and patients aren't necessarily clear on the rules and the expectations. So we got together with several competing hospital systems, outpatient clinics, urgent care centers, or actually urgent care organizations, and came up with 2 documents that one is guidance for providers and one is a notice to patients. And basically this explains and kind of can take the perceived blame off the doctor that's caring for the patient at the time about what they can expect in regards to refills or replacement prescriptions for controlled substances. And the bottom line really is that we don't endorse refilling chronic pain medication or chronic sedative medication. We don't necessarily think that it's safe, and we think it should be managed primarily kind of either from the patient's pain management doctor or whoever is managing the prescription. So this is just one example. These are available on the New York Matters website, and you're welcome to take a better look at this. But what I will say is, since we implemented this document primarily for patients, we saw at 2 large tertiary care centers in Buffalo, opioid prescribing reduced by greater than 50%. Now, that we're not leaving the femur fracture patient out to dry. We're still treating pain appropriately, but we're just being very careful and objective about how we are prescribing controlled substances. This system is built on relationships, and building and bringing new clinics or new outpatient treatment organizations into the mix needs to be done carefully and deliberately, but we also need to do it quickly, right? To offer patients a robust group of treatment options as an outpatient, or when they leave whatever environment that they're being assessed in. We ask our outpatient clinic partners to agree to this mission, vision, value statement. There's not a contract. This is really it. And the most important part of this is this box here, where we expect the values of our program to be reflected in the way that outpatient treatment organizations assess and treat their patients. And the take-home message is, you have to take the patients as they come. So the patient that comes in with no insurance and is a polysubstance abuser needs to be offered the same resources and cannot be automatically disqualified from receiving medication-assisted treatment as the other patient that is fully insured, has a job, has a car. This is what we ask the clinics to agree to before they start. We also understand that not everybody is super comfortable prescribing buprenorphine. So we have a suggested protocol on the website that can be used exactly as you see it listed here, or modified if someone's much more comfortable. So really, if a patient's in withdrawal, they get 8 milligrams of buprenorphine right away. And if that helps, great. We can consider additional dose after. And if not, then we ask that you consider additional diagnoses that maybe the patient's in some other form of withdrawal or something else is going on. We ask that this prescription is standardized so that patients are offered the most flexibility. So if a patient has a clinic appointment in 3 days, we ask still that the prescription is written for buprenorphine naloxone. The combination product is what we prefer, for 14 days, and that reduces the likelihood of a lapse in medication. You'll see as our suggested protocol continues, the referral process, which Kaylee will explain, is kind of the next spot. And we also, in our participating hospitals and referral locations, offer the patient, their family, and anyone with them naloxone. It's not really a kit as much anymore as it is the white box with the nasal spray. So we feel that if a patient comes into the ER and they're in withdrawal, that patient probably should leave with some naloxone. We'll talk a little bit about the voucher process as well. So I'll hand it over to Kaylee, who can explain kind of the nuts and bolts of the referral platform itself.
Great. Great. So this right here is the Matters iPad. In all of the hospitals that participate, there's an iPad just like this one, and this is how you actually access the referral site. So the patient and provider will go through a couple of pages of the referral form to complete all of this information. And this is the first page of the actual referral. This is the first demographic page. So one of the reasons why we like to utilize the iPads as opposed to just accessing the referral site on any other electronic device or on a computer is so that the patient can actually play an active role in scheduling their own appointment and filling out all of this information themselves. So this page right here just has some basic contact information. The patient will be filling all of this out. And then there's a couple key questions that I'll point out. The first is going to be, what type of health insurance do you have? If the patient indicates that they have Medicaid or that they're uninsured, they're automatically eligible for the voucher. We'll talk about in a couple slides how they actually access that voucher, but just know as long as they indicate they have Medicaid or no insurance, they're automatically eligible and automatically given that voucher. There's no other information or forms that they have to fill out. This right here is the second half of the demographic form. So the patient is still filling this out. There's a couple questions in regards to medical history, prior drug use, what kind of treatment the patient might have undergone in the past. And then another big question here, would you like to be contacted by a peer in recovery for support? So if you noticed a couple slides ago on the map, you see a bunch of different regions of where Matters is implemented. So in each of those regions, we work with a local peer organization who agrees to accept any peer referrals that may happen in that region. So a patient can choose to opt in or opt out of this. If they opt in to the peer referral, just their contact information will be sent over to that region specific organization that accepts all of those peer referrals, and they'll contact them typically within 24 hours or so of that of their initial emergency room visit. And then the last question at the bottom, select referral location. So if you were to click that drop-down list, you'd see all of the participating emergency departments, hospitals, inpatient units, OBGYN offices, etc. Basically all of the places where Matters referrals are being initiated. So now going to the next page, the iPad will be handed back to the provider or nurse or tech or whoever might be helping to complete this referral form, and they'll answer a few questions. So the second question that you see there, referral settings, if you were to click the drop down, you'd see all of the different settings where referral could come from. So emergency department, OBGYN office, urgent care center, etc. And then the questions that follow will sort, so they're only applicable to that particular setting. To give you a general idea, the questions that are on your screen right now are all the questions that are applicable to the emergency department. So we would want to know if the patient was given BUP in the ER, if they were given a prescription to take home with them, or to go pick up at the pharmacy rather, were they provided an naloxone kit, and then what was the reason for their visit in the first place. And then the next page here, probably the most important, the patient finally gets to choose which treatment organization they would like to go to or be referred to, and then on which date. The first thing that'll appear is this map. This map automatically sorts based on the patient's zip code. So you can see on the left-hand side, the zip code there, that's the zip code that they entered on their first demographic page as their home address. And so the clinics that are closest to their house are going to populate here. All of the red icons there are all of the different clinic options. You can click on them to see a little bit more information, which is shown on the next slide. So it shows you the clinic name, the address, and then what types of MAT they offer. So all the clinics that we partner with, of course, offer buprenorphine, but it's important to list here, whether they offer methadone or naltrexone as well, so the patient can make an educated decision on where they would like to seek treatment. This here is the exact same information that was on the map, just in a list form. So basically the patient's going to choose which clinic they would like to go to and on which date. They're not choosing an exact time of appointment here, and we'll talk about that on the next slide, how that is determined. So once the patient makes a selection and the referral is officially submitted, a few things will happen on the back end. First, all of this information will fax back to the emergency department. So it'll have all the information that was filled out, some BUP discharge instructions, and then a reminder of the clinic that they chose and the date of their first appointment. So that hard paper copy can be given directly to the patient and they're good to go. All this information will also be faxed over to the clinic. So the clinic will get all the patient's information, the date that they would like to be seen for their first appointment, and they'll reach out to the patient. This is when they determine the exact time of the appointment. If the patient inputted an email address on that first demographic page, everything will also be emailed to them. This right here is an example of what that email looks like. It's showing just right at the top a reminder of the clinic that the patient chose and on which date, and then some BUP discharge instructions. And then if the patient opted into a peer referral, their contact information will be faxed over to the peer organization. And then lastly, if the patient was eligible for a voucher, that'll print to the emergency department, and it'll also be emailed to them if they inputted an email address. This is an example of what the voucher looks like. So on the left-hand side are all of the pharmacies that we participate with. We participate with all Walgreens and all Wegmans locations in New York State, and then a whole bunch of independently owned pharmacies as well. And the right-hand side is information for the pharmacist on how to actually redeem the voucher, verify that the number is legitimate, and then also just some information for their own internal systems on how to input the voucher number and redeem it.
So this is data that's that our partners at the New York State Health Department have populated through Tableau. These are patient zip codes that have been referred for appointments. So we watch this carefully to make sure that new regions we bring on are actually having patients that are being referred from those regions. This is just an example of the variety of referring hospitals. So this isn't all referral locations. These are just hospitals, emergency departments that are referring. And here is just a spread of all the different clinics that were participating at the time that we took this snapshot of data. So we also look at several other variables, and we want to make sure that we're getting buprenorphine into the hands of patients that need it the most. So this represents about over half the patients that were tracked in this roughly 17-month time frame. Shows that about half of the patients were actually getting buprenorphine in the hospital before they left. And about 60% of the patients were getting buprenorphine prescription before they left. Just a couple other programs that are affiliated with the Matters program, a couple other initiatives that are affiliated with the Matters program are Leave Behind Naloxone, which is a partnership with local emergency medical services agencies that they are given state health department or county health department kind of funded naloxone that they're able to leave behind at the scene of any opiate related call. Doesn't have to be an overdose per se. So if there is a patient that was in opiate withdrawal or overdosed at a gas station, that EMS crew can leave a box of Narcan at the gas station. We realize that patients that locations that have opiate related emergencies probably could benefit from having naloxone at that location, whether it's a gas station, an office building, a bus station, or a private residence. We also have naloxone wall boxes that look like an AED cabinet, but are a lot smaller, that we can have naloxone there accessible to the public. Additionally, we have a telemedicine program that has started with with a police department, and we're expanding to other police departments kind of by the week. This is just another way to access to allow patients to access care. So an individual might encounter the police for whatever reason. In this case, the patient would be offered a referral to treatment, and then additionally during the hours of 11 a.m. to 11 p.m. offered a telemedicine assessment by an emergency medicine provider. So these are providers from the University at Buffalo. They all have X waivers. They all have the ability to electronically prescribe buprenorphine if appropriate and provide linkage through the New York Matters program. So if you think about it, this could be a patient that is arrested for shoplifting or in a domestic disturbance. And it comes out in the course of the discussion with the patient and the police, or the individual and the police, that opiate use disorder is a factor. Those patients might be able to be linked up with an emergency physician from their kitchen, from the back of the police car, from the police station. They can be assessed by them. They may be able to be started on MAT right away. And they would also offered linkage to care via the New York Matters network. So they could go from having a police interaction today to getting buprenorphine tomorrow and being linked to care with an appointment in front of a substance use professional within 24 hours. So this is really kind of the overview of the Matters program. We're hoping that some folks might have questions or comments, and we would be happy to answer them. But please visit the newyorkmatters.org website. And then additionally, we wanted to make sure that this program is available to everyone in New York State. And if you live in a region of New York State that you think this might be a good idea, please reach out. It doesn't take 10 hospitals and 50 clinics. It really takes one hospital and 2 or 3 clinics to get a region started. So even if you have the slightest inclination that this could be useful in your area, please reach out. We'd be happy to talk with you and explain how this could be implemented. Again, it's all free. And we just really work to bring referring sites, whether they're hospitals, clinics, together with outpatient treatment organizations. So just one question I see here is what platform is used for the app? This platform is based on the New York State Health Commerce System, which is a New York State Department of Health program. So if you noticed on the referral slides that Keely was talking about, there's a Department of Health logo on the top. The platform was designed by the health department, by the state health department, and is maintained by the state health department. We operate the platform. We offer expansion and can enroll new hospitals and clinics with great ease, actually. So one other question about the AED kit. So these are it's like an AED box, the same concept. It's just a small box with a box of naloxone in it. How is the expiration date monitored? So when we install the boxes, we work with whoever is the agency that's responsible for where we're putting them up. So for example, a transit authority. We recently installed boxes at all the bus stations. So the transit authority works with us. We have a contact there. Actually, they work with the county health department, and they are the folks that keep an eye on those boxes. So what we find more frequently than drugs expiring are naloxone that was taken from the box. So if that was the case, a coordination between whoever is overseeing the boxes and the county health department gets them another box of naloxone to put and replace back into the wall mounted box. So that's what I have for the presentation. And again, please, if there's questions or dialogue, let me know, and we'll turn it back over to Paul.
Thanks, Josh and Kaylee. Just want to wrap up, but give ourselves a few extra minutes. If folks want to chat questions here, or feel free to unmute yourself, turn on your camera. Happy to turn this into a conversation and ask questions, especially those might be relevant for the broader group. We're also going to be emailing a copy of this presentation, or a link to this presentation rather, to everyone if you'd like to watch it on demand again in the future, or for many of the folks that registered but weren't able to join us live, this will be available. I'll also include in that follow-up email contact information for both Josh and Kaylee. So please feel free to ask them questions offline. I really appreciate them sharing this program with us. And I think a lot of us had found it very relevant going through, especially based on some of the questions that I saw come up. So I'll give maybe a last call message if anybody else has any other questions or comments. Otherwise, pausing slowly, going to thank everybody for their time today. Again, Josh, Kaylee, thank you for sharing this information with us, with our group. We're going to archive this on the nysod2a.org website. That address again is nysod2a.org. Please feel free to join. We've got a community there, not only of shared information, but also chat forums for additional questions. And once again, I'll be sending a follow-up to everyone that registered, including you folks that joined us live. If you'd like to watch this again or share this with colleagues, we encourage you to do so. So Josh, Kaylee, thank you again. We appreciate this. It's a fascinating program. Not surprised that it's expanding across New York State, and I'm sure we will see this continue to support folks around the country. So thank you.
Great, thanks.
Bye, everybody.
Thanks, everyone.